Hello everyone, I am Dr. Simone Atkinson with Get to the Point Nursing Notes, and today we are going to do a next gen NCLEX case study on stroke. So the nurse cares for a 68-year-old male client who presents to the ED. So 8 a.m., a 68-year-old male client presents to the ED due to confusion noted by his wife when he woke up this morning. The last time known well was when the client went to bed at 9 p.m. yesterday. Now the client is complaining of dizziness, a headache, unsteady gait, visual disturbance, and the client's wife stated that he was complaining about not being able to see while trying to do some chores. The client has a past medical history of atrial fibrillation, on Coumadin, congestive heart failure, hypertension, hyperlipidemia, gout, transient ischemic attack, coronary artery disease, status post coronary artery bypass graft, and diabetes mellitus type 2. His home medications include Plavix, Coumadin, losartan, simvastatin, diltiazem, and metformin. Client has an allergy to aspirin. Assessment is as follows. Client is alert and oriented ×4, appears slightly confused. Heart rate regular at 85, respiratory rate unlabored, abdomen soft, non-tender, bowel sounds active, skin warm and dry and intact, voids regular amounts of clear yellow urine. Vital signs, temperature 97.7, heart rate 85, respiratory rate 24, blood pressure 170/79. Pulse oximeter 96% on room air, and the client's weight 246 pounds or 112 kilograms. Our first question in the first part of our case study says, highlight the assessment that are concerning. So we take a look. Confusion. Is that concerning? Yes. Dizziness. Headache. Congestive heart failure. It's a history, so not a current problem, so no. Unsteady gait. Yes. Heart rate of 85 is normal. We're not concerned. Visual disturbance. Yes. Not being able to see. Yes. And hypertension or elevated blood pressure at 170/79. Yes. So when we take a look at the rationale for choosing these answers, the client is exhibiting signs and symptoms that are concerning with the choices that we picked. Together, they indicate a potential neurological or even a potential cardiovascular issue that requires immediate medical attention. The confusion can be a sign of a serious condition indicating a stroke, a TIA, or some sort of neurologic disorder. There may be a disruption in normal brain function, possibly caused by a lack of oxygen or blood flow. And the dizziness can be attributed to several different problems. It could be an inner ear issue, a cardiovascular issue, a neurological disorder. But in this case, it could be an impaired blood flow to the brain or another critical organ. We're seeing a sudden or severe headache that can be due to the high blood pressure, or it could be some sort of vascular or neurological event like a stroke or a TIA. Now, the unsteady gait, classic sign, another neurological dysfunction. It could be, yes, an inner ear issue or a musculoskeletal issue, but it definitely looks like it's a sign of a neurologic dysfunction such as stroke. Visual disturbances may be from a neurologic or a vascular problem affecting the eyes or the visual center in the brain and could indicate an impending stroke. Not being able to see or a sudden loss of vision or visual impairment, even if it's temporary, could be a problem with the optic nerve or the brain and does require immediate evaluation. Now, the elevated blood pressure indicates some type of uncontrolled hypertension. This places the client at risk for a stroke or even a heart attack or some other complication. And the complex past medical history of having AFib, CHF, hypertension, and TIA with the presenting symptoms does raise several red flags. So the nurse would anticipate the healthcare provider is going to perform some necessary diagnostic tests to identify what are we going to do for appropriate treatment. Okay, let's look at the next question. All right, so we have the same case scenario with the same scenario and the same vital signs, but the question asks, it says, drag the most appropriate words from the choice to fill in the blank of the following sentence. And the sentence says, the nurse should recognize the client is most likely experiencing what? And from our rationales that we explained previously, I think that we can ascertain that more than likely this client is probably having a stroke. We identified the confusion, the dizziness, and the headache. These are common neurological manifestations of stroke. The sudden confusion can result from the disruption of the normal blood flow to the brain or inadequate blood flow or oxygen supply. And the dizziness and the headache are often accompany a stroke due to the compromised blood flow, as well as inflammation of the blood vessels. The unsteady gait or difficulty walking, that's another classic sign of a neurologic impairment in a stroke. And the client is off balance and not coordinated, leading to the unsteady gait. The visual disturbance and not being able to see, as we said earlier, especially if the part of the brain is responsible for processing visual information is affected. We would see the sudden vision problems. They can include partial or complete loss of vision and can be indicative of a stroke. The patient has a history of atrial fibrillation. So AFib increases the risk of blood clots forming in the heart, which can subsequently travel to the brain and cause a stroke. The irregular rhythm is atrial fibrillation, and it leads to stagnant blood and clot formation in the atrium or in the heart, and these contribute to risk of stroke. Congestive heart failure and hypertension, they are risk factors for stroke as well. The hypertension can lead to weakening blood vessels, making them more prone to rupture or even the blockages, and congestive heart failure can further exacerbate blood flow issues and contribute to risks of cardiovascular events. Now, a TIA or transient ischemic attack that the patient has a history of, that's a sign of an impending stroke, and it can indicate a temporary disruption of blood flow to the brain. So the recurrence of similar symptoms of a TIA, such as the confusion and the headache and the visual disturbances, could suggest a more severe event is underway or is happening right now. The elevated blood pressure reading is a significant concern. High blood pressure is a major risk factor for stroke. It strains the blood vessels and it increases the risk of blood clots and vessel damage. So given this client's extensive medical history, the sudden onset of the neurologic symptoms that we discussed, the presence of the cardiovascular risk, the likelihood is that this client is exhibiting signs and symptoms of a stroke. So we will need to do some rapid medical interventions with this client. We want to confirm the diagnosis, determine the type and the extent of stroke that this client is happening, and initiate the appropriate treatments. It is time sensitive because the interventions such as thrombolytic therapy, if it's appropriate, or a mechanical clot removal with the interventional lab will need immediate attention for the best possible outcomes for this client. All right, so let's take a look at the next question. And the next question reads, same scenario, same clinical notes, no changes in vitals, but we do have laboratory results. And it says, which abnormal lab finding should the nurse address first? So this is our priority question, and we need to know, what should the nurse do first? So the INR level, if you look at the INR level on this client, it is 5.11, which is super therapeutic for our client. So the rationale is that the client's sudden onset of the confusion, the dizziness, the headache, the unsteady gait, we already know that this client is probably presenting with a stroke, and an elevated INR could exacerbate the risk of a hemorrhagic stroke if that's what we find on the CAT scan, which would be bleeding on the brain and would lead to a worsened neurologic deficit. So having that elevated INR of 5.11 requires immediate attention. So if the client's symptoms are indeed due to an ischemic stroke caused by a blood clot, or a blood clot that's occluding a vessel to the brain, we would want to implement rapid initiation of blood thinning medication such as TPA. However, with the current elevated INR, which is super therapeutic, we would not be able to do that, and TPA would be contraindicated in this particular case. Okay. So the nurse's prompt attention to this elevated INR can help facilitate better communication with the medical team. The elevated INR could again interact with other lab values. For example, the patient's calcium is a little bit low, and it could also amplify the risk of this client bleeding. So if you notice, the calcium level was 8.2, which is on the lower end. It's below the normal range. So an elevated INR with a low calcium level could also potentiate the risk for bleeding for this client. Okay, let's look at the next question. So continuing on with the case study, this is our fourth question. We have the same clinical notes. We have the same vital signs, and we have the same lab report. Nothing new here. So the question says, what should the nurse include in the plan of care for this client? Select all that apply. All right, it says, weigh yourself every day at the same time and in same clothes. Measures to reduce intracranial pressure, improve mobility and prevent joint deformities, prevent shoulder adduction, turn every 2 hours, place in prone position for 15 to 30 minutes several times a day if possible, and unless contraindicated, low fiber diet, and restrict fluids to 1 liter per day. So let's take a look and see what would be the correct answer choices for this question. So the first one, weigh yourself every day at the same time and in the same clothing. Our patient has a stroke. So that is not something that we would normally do with our stroke patient, maybe for our heart failure patient, but not our stroke patient. They do have a history of heart failure, so it would be indicated if they did continue having heart failure, but right now the priority is related to the stroke. So would the nurse implement measures to reduce intracranial pressure? Yes. So stroke can lead to increased intracranial pressure, which may worsen the client's neurologic status, and implementing measures to reduce intracranial pressure, such as maintaining the head of the bed at a slightly elevated position, approximately 30 degrees, and avoiding activities that increase intracranial pressure, such as the Valsalva maneuver, can help to improve cerebral perfusion and minimize the risk of a secondary brain injury from the increased ICP. Next, we want to improve mobility, prevent joint deformities, the rationale. Stroke often results in impaired mobility and weak muscles. Inactivity will lead to, or potentially lead to, joint contractures and deformities. So by focusing on the mobility exercises, range of motion activities, the nurse can prevent joint stiffness, muscle atrophy, ultimately enhance the client's overall independence and their quality of life. Okay, we want to prevent shoulder adduction. So shoulder adduction where the shoulder is moving inward can lead to a common post-stroke complication known as shoulder subluxation. So where the humeral head partially dislocates from the joint, and preventing the shoulder adduction through proper positioning of the client and exercises to help maintain joint integrity and function will help reduce pain and allow the patient to remain without potential complications of deformity. All right, next we want to turn our client every 2 hours. The rationale is immobility increases that risk of pressure ulcers, pneumonia, other complications. So regularly turning the client every 2 hours will help redistribute the pressure, maintain the skin integrity, promote lung expansion, and reduce the risk of respiratory issues and skin breakdown. Okay. Next, we will place the patient in prone positioning if we are able to do that. Prone positioning for short periods of time during the day, if the client can tolerate it, it'll help to improve oxygenation. It'll enhance ventilation perfusion. It also encourages postural changes to minimize the risk of complications with prolonged immobilization. But it must be implemented cautiously and with consultation of the medical team to make sure it's okay. All right, and then the last question that said, unless contraindicated, low fiber diet, restrict fluids. That is not correct. We would want to enhance our high fiber diet. The patient is not mobilizing, so they could develop constipation. So due to that factor, we would want to improve and increase physical mobility and increase our fluids when the patient is not able to move, because of the potential side effects also of medication. So a high fiber diet would promote regular bowel movements by adding bulk to the stool and facilitating easier passage through the GI tract. And then adequate fluid is needed, and it is more recommended for having 2 to 3 liters of fluid per day. So this answer choice is incorrect. Okay, let's look at our next question, question 5 of 6. So, any new information? No new information. We have the same scenario, the vital signs. We have the labs. And what is the question? The question is, which of the following interventions would the nurse anticipate the healthcare provider to order for this client as a priority, and which are contraindications? So which are priority for our stroke patient and which are contraindicated? So let's take a look here. So the first one is a STAT non-contrast CT scan. So a non-contrast CT scan is crucial in evaluating stroke on our patient. It helps to identify the type of stroke. Is it ischemic or is it hemorrhagic? It'll tell us more about the location of the clot. If there's bleeding, how much bleeding is involved. So we do need a non-contrast CT scan. All right, we also want a consult with our neurology stat. The rationale, a neurology consultant is necessary to help determine the severity of the stroke, determine the best course of treatment. They're specialized in the neurologic care of these patients. So rapid involvement of the neurologist specialist is important in helping with decision making for this client. Next, vitamin K, 5 milligrams IV push over 30 minutes. What's the rationale? The administration of the vitamin K is ordered to reverse the effects of the anticoagulant medication, which was warfarin, especially with this patient's elevated INR of 5.11. So this intervention will help to normalize the blood's ability to clot and reduce the risk of this client converting to a hemorrhagic stroke. All right, nicardipine IV titrate, systolic blood pressure 140 to 160 millimeters of mercury. And the rationale for this medication, this is also correct, is to manage the blood pressure and titrate it in a tighter range For our clients with strokes, a high blood pressure can exacerbate the risk of bleeding. It can contribute to poor cerebral perfusion. So the nicardipine, which is a calcium channel blocker, is used to lower and control the blood pressure within the target range. And we want the target 140 to 160 in this particular question. Next, it says titrate oxygen greater than 94%. Yes, so adequate oxygenation is crucial for brain and tissue perfusion. Maintaining the oxygen saturation above 94% will help to ensure sufficient oxygen supply to the brain and other vital organs, promote optimal recovery, and reduce the risk of complications for our client. So what about giving TPA 0.09 milligrams per kilo IV push and 0.81 milligrams per kilo over 60-minute, max of 90 milligrams. Well, the dosing is correct if we were going to give TPA to this client. But considering that the client has an ischemic stroke with an elevated INR of 5.11, it would be contraindicated for us to give TPA to the client even though they have an ischemic stroke. So this is a contraindication to this particular client because of the potential for bleeding. Would we resume the Coumadin that they were taking at home, 5 milligrams PO daily? No. So again, given the INR level, the patient is super therapeutic. We do not want to give Coumadin. What about a non-rebreather mask? Well, no, the vital signs show that the pulse ox is at 96%. They're on room air. We want to titrate oxygen to maintain a SAT above 94%. So oxygen therapy should be carefully titrated to avoid abrupt changes in the oxygen level. And also too much oxygen can also damage the lung parenchyma, causes the free radicals. So we want to minimize adverse effects for this patient. So we would not use a non-rebreather mask and have them become have hyperoxia. That would exacerbate damage to the brain tissue as well. All right, neurochecks Q6 hours and PRN. The order for neurochecks Q6 hours may not be appropriate in the management of a stroke patient. The frequency is not often enough. So stroke management requires more frequent neurologic assessments, especially in the initial hours after the symptom onset. So neurologic changes can occur very rapidly. So delaying the assessments every 6 hours would be inappropriate, and we would not detect worsening symptoms promptly. All right, aspirin, stat, and Q-day. Again, the patient has a high risk for bleeding at this particular time. I would anticipate the physician may possibly hold the aspirin until the INR level, is at a therapeutic range. Also, the patient is allergic to aspirin. We see that in our case scenario. It says the patient has an allergy to aspirin. So we would not want to give aspirin to someone who is allergic to aspirin. INR level QOD, again, the INR level, we would want to closely monitor that. So doing an INR level every other day is not frequent enough for this particular case scenario. What about ketorolac, IM 30 milligrams Q6 hours PRN for pain? Where it's important that we do manage our pain and manage the pain in our stroke patients post-stroke. Again, this medication is a non-steroidal anti-inflammatory and has the potential to cross-react with aspirin in patients with aspirin allergies. So this patient cannot receive ketorolac for pain management. Okay, and then again, with the elevated INR and a risk for bleeding and the allergy in combination would be contraindicated to give this to this patient. Okay, we are on question 6 of this case study, last question for the case study. And there's some new information at 1900. So it says, at 1900, the client has become confused and disoriented and is now complaining of a severe headache. He complained of feeling nauseous and vomited ×2. His NIH score increased from 4 to 16, and on assessment, his right pupil was dilated and non-reactive to light. So this is quite concerning. And let's see, what is our question asking us? All right. So here was the case study. The additional information was right here. And I gave you the answer, but the question asked us, based on the new assessment findings, the nurse should recognize that the client is most likely exhibiting increased intracranial pressure. All right. The other choices were a normal response to ischemic stroke changes, autonomic dysreflexia, and agnosia, but those answers were incorrect. Why? Well, first of all, the increased intracranial pressure, the symptoms that we saw, the increased, the severe headache, the nausea, the vomiting, the altered level of consciousness, and the neurologic deficits with the dilated non-reactive pupil. These are strong suggestions of potential increased intracranial pressure and even possibly herniation. And an elevation in intracranial pressure can result from various conditions, including bleeding. Remember, this client was at high risk for bleeding. It could be edema, an expanding mass within the brain, but this client is a stroke client. Maybe they converted to a hemorrhagic stroke, which caused bleeding in the brain along with their increased INR level. So this can lead to compression of the brain structures, and we would see that in the symptoms that we are now seeing in this client at 1900. Now, a normal response, while ischemic strokes can lead to neurologic changes, the severity of these symptoms definitely indicate that the patient is having a huge problem, and potentially it is increased intracranial pressure. Now, autonomic dysreflexia is not correct. This is what happens in our clients with spinal cord injuries at or above the T6 level. And it's characterized by an increase in the blood pressure that's triggered by a certain stimuli. It could be something in the bed. It could be their bladder distension. It could be constipation. So those are things that would cause autonomic dysreflexia in a spinal cord patient above the level of T6. So that is not correct. And then agnosia, if you recall, refers to the difficulty in recognizing objects, right? Recognizing sensory stimuli. So it's unlikely to cause these neurologic changes that we are seeing, which involves the change in consciousness, headache, the vomiting, and the pupillary changes. These are definitely indicative of a patient exhibiting increased intracranial pressure. Okay, congratulations. You endured if you've made it this far to the end of this video. And this was your stroke case study, your next-gen case study for stroke. So you are one step closer to becoming the best nurse ever. If you found this information helpful, please give the video a thumbs up, subscribe to the channel, continue to explore our concise, get to the point NCLEX videos, and stay committed to your studies. These insights will definitely empower you to confidently tackle the essential aspects when approaching your next-gen case studies. So thank you, and we'll see you in the next video.